There isn't always a moral obligation to perform CPR. It's often assumed that medical professionals ought to provide life-saving measures, such as CPR, when the patient does not have a do not resuscitate, or DNR for short, order. But Jeffrey Bishop and his colleagues do not think that we should always presume consent to CPR. In their paper, Reviving the Conversation Around CPR and DNR, Bishop and colleagues argue that we should not always presume consent to CPR in cases where medical treatment is futile. But shouldn't we always attempt resuscitation if a patient doesn't have a DNR order? The reason you might think so is probably because you think that the patient should be thought of as consenting to life-saving measures in the absence of a DNR. We can capture this rough idea in the following argument. We ought to presume that everyone without a DNR order consents to life-saving interventions. If we ought to presume that those without a DNR order consent to life-saving interventions, then we ought to enact those life-saving interventions for those individuals. Therefore, we ought to enact life-saving measures for everyone without a DNR. But Jeffrey and colleagues take issue with premise 2 here. It is not always the case that we ought to provide CPR to patients, even if there is presumed consent to life-saving interventions, because such treatment may be medically futile. The authors argue that the idea of presumed consent to CPR is the product of an era of medicine where society viewed the profession with an excessive optimism about its ability to keep patients alive. In practice, however, the success rate of CPR ranges from 24 to 40% in a hospital setting, and the likelihood of success decreases for patients in advanced age with kidney, liver, heart problems, or a terminal illness. Once we realize that medicine is limited in its ability to ward off death, we will be more willing to give up the idea that presumed consent for CPR should be universal. In cases where intervention would be medically futile, there may not be a moral obligation to provide CPR. As a result, the authors suggest that CPR need not always be provided, even for patients without a DNR order, since CPR may be medically futile. You might respond that we really can't know if any treatment is futile, even if it generally has been unsuccessful in the past. Even though we might have data about how other people with similar conditions fare given a certain treatment, there is nothing close to a guarantee that this patient, the one right in front of you, will not survive if she were given CPR. But the authors think that uncertainty about the success of administering CPR is likely problematic because of the physician's focus on the symptoms of the disease and not the long-term prognosis of the patient. Historically, the likelihood of success of CPR has been largely determined on the basis of symptoms such as the patient's cardiac rhythm. However, once we evaluate the patient's long-term prognosis alongside her present symptoms, it will become clearer whether or not CPR will be medically futile. So, in cases where the patient has very little chance of survival, such as an elderly patient with metastatic cancer, it may be morally permissible to forgo CPR, even if the patient does not have a DNR order. Thank you for watching 5 Minute Ethics. Please like and subscribe.